minutes, you're working with some of them. The National Business Group on Health, Bridges to Excellence, of course. We don't have to go through all this. You get the idea that groups like Prometheus, oh, and by the way, Rick, Alice Gosfield is 5 blocks from my office, the co-founder of Prometheus. Alice's father was an attending when I was an intern and resident at the Graduate Hospital. He was a pain in the neck. Maybe that affected Alice in a deep psychological way and led her to create Prometheus. What do you think? It's this deep psychology of all of this. He was a wonderful guy, but he was one of those attendings who would make rounds earlier than the house officers and totally devoted to his patients, a very kind of old school, amazing model you don't see too much of today. So back to the business at hand. This group, they're trying to work with you and me to sort out this public accountability, transparency, lack of an evidentiary basis, unexplained variation. They understand these themes as well as anybody in this audience, myself included. And they want to work with us to sort of sort this out so we could do a better job and create better value for the money that we're spending. Sounds reasonable, but making it really work, the devil's in the details. So this is sort of the environment that grew and sort of promoted health reform. So here's a summary way of maybe thinking about this, and I want to come back to this exact slide. So here's the challenge. I would ask you all to think about where is spectrum on this graph. So let's explain what we're talking about. So time is on the x-axis from left to right. Value is on the y-axis. So many people would argue that we're in this era of public accountability, first described by Arnold Relman. Remember him, the old editor of the New England Journal? Back in 1988, Relman said the decade of the 90s would be the decade of public accountability. Okay, pretty prescient. By the time we got into the 90s, people were saying, well, now we want to give consumers better information about everything Spectrum and Jefferson does, and will allow them to make their purchase decision. So we are talking about pay for performance, that's that P for P, greater market sensitivity, turn every patient into a savvier shopper. Just like John Stossel said, no one ever said to him, what's that heart surgery for his wife going to cost? Never came up in conversation. And then part 3, which I'll explain in a little bit, can we really create care that crosses what Uncle Sam calls the quality chasm? So here's the challenge. Where's spectrum on this, if you would, spectrum of ideas from accountability to consumerism to crossing the quality chasm? And I'm going to define these in a minute. Okay, so first we need a definition of quality. It took us 20 minutes to get to this. So you could read along with me the degree to which health services for individuals and populations, there's that population term again, increases the likelihood of a desired health outcome, pretty important, and is consistent with current professional knowledge. So this is the Institute of Medicine 1991 definition of quality. Probably the most widely accepted definition we currently have. To me, it says there's sort of 3 action components here. Number 1, a population focus. Well, that's all well and good, but the last time I looked, which was yesterday, at Jefferson Medical College, we're still teaching one patient, one problem, one at a time. I'm pretty proud of it. So in your new medical school, you're going to have a population focus, right? And you're going to teach new medical school students and the doctors of the future to care about the population. That's what it says here. It's incredibly hard to do. Why? Well, let me go over here for emphasis. When you're in that examining room, do you care about the population of patients with your problem? Well, of course not. You care about your problem. And that's how we're paid, at least currently. So part 1, a population focus. Part 2, consistent with current professional, part 2, likelihood of a desired health outcome on the part of whom? On the part of the patients. Well, that means we've got to ask the patients what their desired health outcome is. Yikes. How are we going to do that and get paid for it? Another challenge under reform. And number 3, of course, consistent with current professional knowledge, that's our code word. You and I know that as evidence-based medicine. So 3 things. Population, ask the patients, practice based on the evidence. That's a tall order. So here we are. October 2010, the 10th anniversary of the publication of this handy-dandy little book. Everybody here has seen this, read it, I hope. You certainly remember this book. So John Stossel even sort of alluded to this, and we could quibble about the numbers. Is it 100,000 lives? Is it 200,000? Here's the main message, 2 take-home points from this book from 10 years ago. Medical error, everywhere but Spectrum and Jefferson, is the 4th leading cause of death in the United States. So that was the answer to the question somebody raised earlier today in those graphs John was showing. The 4th leading cause of death in the United States is preventable medical mistakes. Second thing this book did, now I want to show you with a couple of PowerPoints. Second thing this book did is it enabled us to sort of have a conversation about medical error. So here's the front page of the New York Times website just about a year ago. You remember those 2 Northwest pilots? They were deep in conversation and 150 miles off course until an astute flight attendant knocked on the door and said, "Wake the F up." Fortunately, landed the plane, everybody's safe, no problem. Front page news for 3 days worldwide. Well, in those 3 days, several thousand patients died from preventable medical mistakes. You didn't see that on the front page of the New York Times website because there are still many of us who don't even believe that this occurs. So the other thing this book did is kind of contributed to the conversation like this. Half of what doctors know is wrong, and like we like to kibitz with our third-year students, the only thing is we don't know which half. Confuses the daylights out of them. Or how about this? In America's most important medical journal, USA Today, why do so many still die needlessly in hospitals? Well, it's a pretty important question. Or my favorite, Time magazine a couple of summers ago, what doctors hate about hospitals? So this is too big a group, but I usually like to sort of take a poll. What do doctors hate about hospitals? It's really fascinating what you learn. My favorite answer over the last sort of 5 years of using this prompt is elevators. What do doctors hate about hospitals? Elevators. That was my favorite answer. Must have been like a 20-story VA building and they hated waiting for the elevator or something crazy like that. But of course, the answer to the question here? Well, first, why would it make the front page of Time magazine? So this is about 8 physician families egregiously harmed from preventable medical mistakes and their stories. So the answer, of course, what do doctors hate about hospitals? Being a patient in one is the right answer. So Rick didn't have time to get into all the details, but right now I'm on the board of a 4-hospital system in suburban Philadelphia. And this is a photocopy of a pre-op clearance from February 2010 that made it to the board quality committee because this patient was cleared for surgery. And I wanted the board members, most especially the non-doctors, to see February 2010, the kind of challenge that we're facing. And, you can't read this, of course. And this passed muster and cleared the way for that patient to go into the operating room. A completely illegible doctor note. But, this doesn't happen in the modern era. Right? Well, of course, totally incorrect. Just less than a year ago. So our school is sort of trying to study, like when errors do occur, what's their impact? How do we get around this? How do we teach a whole new generation of medical students about their role in preventing error? With regard to that hand washing story, back when I was a patient, so this is from a year ago from AMA News at a infectious disease conference in the United States, where gender-appropriate medical students were in each of the 2 lavatories with a clipboard doing direct observation. The punchline of this is I just want to thank all the ladies in the room for bringing the average up to 77%. So these are the kinds of challenges, of course, that we face, leading to the 2001 publication of Crossing the Quality Chasm, Ditto what I said about Tu eres human. I'm assuming you've all read this book. You know all about it. You know that it's a description of a future that has sort of 6 key domains, and let me just quickly tell you what those are, because you've baked those domains into your Vision 2020 statement, whether you appreciate it or not, they're all in there. So, of course, we want a system characterized by the following 6 critical issues, right? Number 1, it must be safe. That's our core, everything we're all about, above all else, do no harm. Will care ever be error-free? No. Our goal is what? To make care harm-free. And the other domains follow. Care that's effective, patient-centered, timely, equitable, and efficient. And we don't have time to go through the definitions. You could probably sort that out pretty well yourselves. So in 2001, Uncle Sam, via the Institute of Medicine, got the smartest people in the business together. It took them 2 years to publish this list of 6 things that will